Welcome everyone to this case challenge series. Today we will be starting with the topic of cyanosis. So I want 3 volunteers for this. We have 3 cases. So a 48-year-old gentleman with background history of chronic ethanol consumption, which is about 360 ml per day for about 20 years, and a reformed smoker who presents with the history of progressive abdominal distension and breathlessness, which has increased since 2 weeks. In the past history, he says he's been having recurrent hospitalizations for on and off abdominal distension and breathlessness since about 5 to 10 years. And he's been compliant with all the medications. However, he's not been able to cut down on the alcohol. So on examination, hemodynamically he is stable. Apart from mild tachycardia and tachypnea with a respiratory rate of 28 and hypoxia, which is about 70% on room air. The saturation is 70% on room air in the supine position. On examination, icterus and cyanosis was present. Systemic examination showed a moderate splenomegaly with evidence of free fluid in the form of shifting dullness. Cardiac examination showed grade 2 out of 6 mid-systolic murmur in the pulmonary area. Respiratory system was unremarkable, with neurological examination revealing no signs of hepatic encephalopathy. So what do you want to do next? Whoever volunteered, can you just introduce yourself?
Hi sir, I am Pawan from JJMMC.
Okay, welcome Pawan. So what do you think is happening to this patient now?
Sir, because of the ethanol consumption, he might be having some liver injury, sir.
Okay, good.
That might lead to some vascular abnormality.
Okay. So why do you think there is cyanosis here?
Sir, because of some cardiac cause, sir, because he is having some murmur in pulmonary area.
Okay, so you are thinking of a cardiac cause. Very good.
Yes,
so I also, can you just see this
central
case here?
cyanosis.
So what
Yes.
kind of cyanosis is this?
Central cyanosis.
Central cyanosis, excellent. So we have a patient here with central cyanosis, a decompensated chronic liver disease. With why do you think the oxygen saturation is only 70%?
So maybe because of pulmonary hypertension, he is not able to breathe properly.
Pulmonary hypertension. Okay, pulmonary hypertension. Okay. So do you want to look for anything else? You want any investigation?
Chest X-ray, sir.
Chest X-ray. Okay, chest X-ray was normal. I'll come to the chest X-ray. So because he has this hypoxia, so you want to really look at the arterial blood gas. So this was the X-ray. So anything you're noticing in the X-ray?
X-ray.
Is it clear?
Yes, sir. It is clear, sir.
Okay.
Cardiomegaly.
Cardiomegaly, not really. Okay. Anything else near the pulmonary area? This is the pulmonary area. This is the pulmonary prominence here. Correct?
Yes, sir. Yes, sir.
Okay, good. So here in the left lower lung fields, there is some opacity.
Yes, sir.
Okay. So let's look at the ABG now. So this X-ray is just X-ray PA view. There is no evidence of any obvious cardiomegaly or shunts that are there. Shunts difficult to comment upon. There is no obvious cardiomegaly, and some prominence in the pulmonary area. Pulmonary bay looks a little full. Yes. Apart from that, we don't have anything much to explain this hypoxemia that was there. So here again coming to the ABG. So pH, this was the arrow is after patient is in sitting position. Yes. So initially he was supine, and that time the ABG was taken. So ABG is showing a pH of 7.46, a PCO2 of 28, and a PO2 of 65, and a saturation of 70%. And on making him sit supine, so his pH was almost it just dropped to 7.2, and there was a massive drop in the PaO2.
Yes.
Okay. So what do you think is happening here? So the important thing is, so we'll finish the whole thing. So significant things are the PaO2 dropping and the saturation which is dropping on the patient sitting forward. In sitting position, this is what is happening. And so let's say there is hypoxemia. So the first thing what we do is we start the patient on oxygen. So this is normal what we do. So on starting oxygen, so you see there is no improvement. So what do you try to conclude with all this, Pawan?
Sir, the respiratory tract is all right, sir, but is unable to expand the lungs, sir, like lower lung field.
Okay, but can this cause so much? This does this X-ray look like it can cause so much of a
No, sir.
hypoxemia? A small patch, I agree here. Maybe there is a small patch here. Can this explain the entire hypoxemia? And what is this exactly? On sitting, there is a fall in the saturation. Anything, it just rings a bell?
Platypnea.
Platypnea, excellent, platypnea. So he's worsening on sitting forward, and there is desaturation that we are seeing. So this is called as orthodeoxia. There's a drop in oxygen saturation on sitting forward, and the breathlessness is worsening. So worsening breathlessness is platypnea. The evidence of fall in the saturation is called as orthodeoxia. Okay, so what do you think is here? What is exactly happening here?
Not so.
You can try. Okay, what are the complications of cirrhosis?
Ascites.
Ascites, good.
Oh yeah, sir. Then hepatopulmonary disease.
Yeah. Correct. What did you tell?
Hepatopulmonary syndrome.
Excellent. So hepatopulmonary syndrome. Okay. Then anything else? Where all the vasculature is there? One is in the lung. What about the liver? This one, kidney?
Varices, then encephalopathy.
Good.
Hepatorenal syndrome.
Common ones is encephalopathy, portosystemic encephalopathy, esophageal varices secondary to the chronic portal hypertension. Then they can develop something called as a hepatorenal syndrome, HRS. The same vasculature there. If it's affecting the lung, you can call it as a hepatopulmonary syndrome or a portopulmonary hypertension that can happen in the lung. These are the common things. These are rare. Hepatopulmonary syndrome and portopulmonary hypertension is a little rare. Okay. So what is the approach we have now? So good. So good thinking, Pawan. So I'll continue from here.
Yes, sir.
Good.
Thank you, sir.
Okay. So whenever we have oxygen, so we are giving oxygen to the patient and there is no improvement in the saturation. So that means that the respiratory tract must be almost all right. So on giving high flow oxygen, at least there should be some improvement in the oxygenation. So if there is no improvement, that means it's unlikely to be a respiratory cause. So if it has to be a cardiac, so then the other thing left is for saturation to fall is a venous blood that is mixing with the arterial blood. So there should be some shunt that should be present. Okay. So where is the shunt that can be present? So this shunt can be at the level of the heart or outside the heart, that is in the lungs. Okay, so it can be in the lungs or it can be in the heart. So in the heart, if it is present, so either it should be a right to left shunt. The right to left shunt can be at multiple levels. So it can be at the level of the atrium, it can be at the level of the ventricle, or we have the pulmonary artery that comes out and the aorta that comes out here. And there is a common communication, which is the ductus arteriosus. So if there is a Eisenmengerization or increase in the pulmonary pressures on the right side of the heart, then we can also have some phenomenon like this, wherein pulmonary artery to the aorta. So this is at the level of the heart. So in the lungs also, so if this is my artery and these are my multiple capillaries, and this is at the venial end. So this is my arterial end, this is my capillary end, and this is my venous end. So there can be some shunt directly from the arterial end to the venous end here, or there can be some pulmonary vessels that do not undergo oxygenation and directly get shunted to the pulmonary vein. So these are the two things that happen. So this is what happens in hepatopulmonary syndrome. So the first thing what we have to do is now look at the presence of shunt at the level of the heart, correct? So if it is not at the level of the heart, we have to look at the extra heart, so extra cardiac shunt. So these are the two things we look at. So let's say we did an echocardiogram. So here we have the possible diagnosis of hepatopulmonary syndrome because we had a platypnea and orthodeoxia, which is characteristic. So let's see at the so I'll just show an echo clip. So this is at the level of the heart. So you're doing an echo. So this is called as the apical four-chamber view, wherein you are having four chambers. This is the left ventricle, this is the left atrium, this is the right ventricle, this is the right atrium. So either there can be a problem, so there can be a acute heart failure, or there can be severe pulmonary hypertension, like Pawan said. So here there is no dilated RA-RV or LA-LV. So it looks like the heart function is normal. So here this is the LV function. So LV also looks okay. And we look for the presence of any, since we got a murmur there. So we look for any mitral regurgitation. If it is an acute MR or something like that, we have to look at it. So here we don't see anything. So what we do, something is called as a bubble study. So I'll explain the concept of bubble study. So let's look at this image now. So we are going to inject agitated saline bubbles inside the right side of the heart. It has to, via the IVC or SVC, you will inject the bubbles. And once the bubble enter the right side of the heart, normally what happens, from the right side, they enter the pulmonary circulation and they are destroyed. So bubbles will not come to the left side of the heart normally. In case there is an intracardiac shunt, like a right side to left sided shunt, so as soon as they come to the right side of the heart, they will immediately come to the left side. So that is one possibility. A second possibility would be if there is a pulmonary shunting, wherein they will come after some cardiac cycle. So no, their cutoff is taken as 3 to 4. So if the bubbles reach within 3 to 4 cardiac cycles, it is probably a intracardiac shunt. If it is coming after 4 to 5 cycles, it is probably an extracardiac shunt. So let's look at it carefully. So here immediately we are filling this right side of the heart with saline. And see, this is after about 3 cycles, the entire left side is getting filled. Okay. So this is what is the extra pulmonary shunting. So this is occurring because of a pulmonary shunt. Okay. So this is what we call as a bubble study. So bubble study is simple. It's not 100% necessary to know, but it is common actually. We had recently a case. That is why I just put this up. So this is the SVC and IVC, let's say, and this is the right side of the heart. And let's take this as a left side of the heart. So if you are taking this, so if I'm going to agitate saline, so let's say I'll inject saline here. So it reaches the left side or the right side of the heart. Once it reaches here, if there is a shunt at the level of the ventricle, so it immediately passes through here. But let's say after 3 to 4 cardiac cycles, so it has to pass through the pulmonary vessels and then come inside the lungs to the left side. So this is what is bubble study. So here we made a diagnosis of hepatopulmonary syndrome. Okay, so with that introduction, yes, good. Hepatopulmonary syndrome, most of you have the diagnosis, good. ASD with Eisenmenger's, that is also good diagnosis. Okay, so we'll come to the topic cyanosis. So cyanosis occurs when the amount of oxygen bound to hemoglobin is very low. So this is the concept for cyanosis. So which means that there is deoxygenated hemoglobin that is more in the blood. So if it is more than 4 to 5 grams per deciliter, that is when we call a cyanosis that is going to be manifest. And also remember, very important point, that cyanosis may not be evident in a patient with severe anemia. So what can be the causes for a cyanosis? Either it can be a deoxygenated hemoglobin or it can be an abnormal hemoglobin. Okay. So how does this deoxygenated hemoglobin is going to be generated? Okay. And abnormal hemoglobin, so I'll come to it. I have one case for abnormal hemoglobin as well. So we can broadly divide cyanosis into a central cyanosis and a peripheral cyanosis. What do I mean by it? So central, which means central to the body, wherein there is an impaired gas exchange at the level of the lung, or there is a cardiac shunt or right to left shunt. So the pathophysiologic mechanism is a hypoxic hypoxia that develops in a central cyanosis. In a peripheral cyanosis, it is because there is a very slow flow from the vessels. So that can lead to a peripheral cyanosis, wherein the tips of the fingers and the extremities change the color. So cyanosis comes from the word which means cyan, which means blue. Okay. So how do we remember the causes for a central and peripheral cyanosis? So we can remember this easy mnemonic, which is palms for central cyanosis and cold for peripheral cyanosis. Because peripheries, when they are cold, you can develop peripheral cyanosis. So remember this mnemonic. So central cyanosis occurs wherein there is a polycythemia, high altitude. Why high altitude? Because the effective oxygen in the high altitude is low. The oxygen dissolved in the air itself is low. So that is why you will get hypoxemia there. The PaO2 will be low in high altitude. A lung disease or an abnormal hemoglobin like methemoglobin or self-hemoglobin and a shunt. So we saw an example of shunt here, which is a pulmonary shunt or an extra cardiac shunt. In peripheral cyanosis, most common is a cold, which means a peripherally the patient is cold, so you can have a vasoconstriction. So that can cause a peripheral cyanosis or an obstruction, wherein there can be a vascular obstruction. Let's say there is a thromboembolism somewhere, or a Raynaud's phenomenon of frostbite, etc. Or there is a reduced cardiac output or an LV failure and shock. So these are the common causes for a peripheral cyanosis as well. So just I'll try to put this across. So if this is my blood vessel, so there is going to be some cells and there is going to be some fluid as well. Okay. And there's going to be a laminar flow that is normally occurring. So this flow can be reduced by multiple mechanisms. So whenever there is a slow flow here, that is what is going to cause a peripheral cyanosis. So let's say there is some vasoconstriction. So vasoconstriction occur when there is frostbite or an autoimmune phenomenon like a Raynaud's. Raynaud's can be a primary or secondary Raynaud's. Secondary is secondary to autoimmune condition. Primary Raynaud's may be commonly seen in young females. And how do we distinguish primary Raynaud's from a secondary Raynaud's? Can anyone tell? How do you distinguish a primary from a secondary Raynaud's? Anyone? Anyone can try? There's a special investigation for that. Antibodies, yeah. Okay. If it is secondary, you will get antibodies. Good. Any other cause? Yeah. Okay. If it is secondary, you will get antibodies. Okay. So I don't see anything in the chat as well. So there is something called as nail fold capillaroscopy, wherein you look at the nail bed and look at the capillaries in the nail bed. So if the nail bed capillaries are normal, there is some morphology that is there. So if it is normal, it is probably a primary Raynaud. If it is altered because of a vasculitic phenomenon, that will be altered. So that is how you distinguish a primary and a secondary Raynaud. And also other systemic manifestations will be in secondary Raynaud. So that is one way. So one is the vasoconstriction that can occur. One more is if the viscosity of the blood increases. So where can you get hyperviscosity? It can be a part of leukemia, or you can get hyperviscosity in paraproteinemias like multiple myeloma, amyloidosis, Waldenstrom's macroglobulinemia. So wherever you get a paraproteinemia, you can have this hyperviscosity again. And if there is cryoglobulin deposition at the level of the vessels, that also can cause a hyperviscosic phenomenon. So this is how it is peripheral cyanosis. is that the utilization at the level of the periphery is more. So that is what is peripheral cyanosis. Okay. So we understood how we understand central and peripheral. So central cyanosis at the level of the heart. So some shunt here, an ASD, VSD, or a PDA with an Eisenmengerization. So these are the common causes for a shunt that can occur. It should be a right to left shunt. Okay. Any cause for a right to left shunt can cause in the cardiac, in extracardiac at the level of the pulmonary vessels. And let's take this diagram to understand the respiratory cause. So respiratory, if this is my alveoli and this is my blood vessel, so this is my respiratory membrane. This whole thing is called my respiratory membrane. So oxygen in the air, if it is low, you can get hypoxemia or central cyanosis. As it comes to the alveoli, if there is an alveolar collapse, you can get, or if there is increased fluid here in the interstitial space that is preventing the flow of oxygen, that can also cause a cyanosis. Or if there is a destruction to the vessels here, something like an ARDS, so that can also cause a central cyanosis. So this is at the level of the respiratory membrane and at the level of the heart and the shunts. So we'll go to the next case. So these are the common causes for cyanosis. So can someone tell me, you can just put it in the chat box, where all do you look for central cyanosis? Where all do you look for central cyanosis? I'll take questions at the end. Okay. Where all do you look for central cyanosis? Nose tip, good. Tongue, where in the tongue exactly? Dorsum of the tongue, good. Good, good. Mucous membranes, okay, good. Anywhere else you want to look for? The oral cavity, tongue, lips. Yes, excellent. Ear lobules. Okay, anywhere else? When you have cyanosis, you have to make a distinction between whether it is central or peripheral. So where are the sites you look for and what maneuvers you might do to help distinguish these two. So you should also have to look at the tips of the fingers, the digits. So in the upper limb and lower limb, you look at the digits. If there is, yes, excellent. So fingers. So if there is some cyanosis. So if I say only one site you have to examine to help you distinguish between a central and peripheral. So which is the site you will examine? Only one site, only one choice I'll give you. Tongue, excellent. Everyone is telling tongue. Good, 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 good. So tongue, exactly. So tongue is the first site you will examine. And I think Pavan it was who said you have to warm the hand. No, 1+. I don't know who's 1+. Okay. So when you warm the extremities, so there will be some vasodilatation. So if it is because of a peripheral cause, the cyanosis may disappear with warming of the digits. So that is one more way you distinguish between a central and peripheral cyanosis. So now we know what is cyanosis, why cyanosis occurs. Either abnormal hemoglobin or the quality of the hemoglobin is lost, like methemoglobin and sulfahemoglobin. And we know the central and peripheral cyanosis. So any other volunteers, anyone interested in pediatrics? I have a pediatric case here. So whoever is interested, please raise your hand. We'll unmute you. Any takers for the next case? It's a simple case. We will go through it together. Anyone can volunteer. Anyone can volunteer. If you volunteer, the discussion will be more fruitful. That's all. Anyone volunteering? I don't see any names. Guys, someone volunteer, no? it's a simple case. Okay, Pawan has again raised his hand. Okay, Pawan, we'll just unmute you. Yeah, you're unmuted. Okay. So we have a 5-year-old male newborn infant who was born in 39 weeks of gestation. So the important history was it was a full-term normal vaginal delivery. 23-year-old mother, G2, P2, with no bad obstetric history. And the baby cried immediately after birth. The prenatal serologies were non-reactive. The Apgar score was very good, 8 and 9 at 1 and 5 minutes of birth. Initial physical examination was normal. He stayed in the mother's room. He was breastfed immediately 1 hour after delivery. And at 5 hours of age, the second feeding, the baby started becoming tachypnic and cyanotic. And immediately, as soon as the baby started becoming cyanotic, he was taken to the nursery or the ICU. He was shifted to the ICU. So on examination, vitals were stable. These were the vitals. The heart rate was 145. The respiratory rate was 78. So the baby is tachypnic with some indrawing. The blood pressure was 67/38. And a room air oxygen saturation was 82. Okay, so the important thing is the room air saturation is 82 and the respiratory rate is 78. The anthropometric data is normal, it is 50th centile. So the child is alert, there is no dysmorphic features, and the child is a term baby which is mildly cyanotic. Cardiac, so what do you think at this point? Pawan is there, no? So yeah, Pawan.
Sir,
What all
it
goes to
might
your
be
mind?
tachypnea, sir.
Good. Tachypnea and cyanosis. So how do you
Cyanosis.
relate these two? Tachypnea, cyanosis, and desaturation, which is hypoxemia. So how do you relate
Maybe
all these?
some respiratory cause.
Respiratory cause. You want to think of a respiratory cause, okay. And within 5 hours, the child is becoming cyanotic. So you want to think of a respiratory cause. Excellent. Any other cause you want to think of?
It may be because of cardiac cause also, sir. We don't know.
Okay. So the first thing would be whether it is respiratory or a cardiac cause. So here we see the systemic examination is showing a ejection systolic murmur of grade 2/6 in the lower left sternal border. So this is somewhere near the tricuspid area. So nowadays the conventional term of calling mitral tricuspid pulmonary aortic area is actually not recommended. So you just say apex, lower left sternal border, upper left sternal border, and upper right sternal border. So we thought of a respiratory cause, we have a cardiac cause in mind. So
No.
how does the examination help us? So here we have a
Cardiac
grade 2
cause.
systolic murmur. The lungs are clear. There is no organomegaly that is noted. And the next thing that we did was oxygen. So the first thing we give is oxygen, correct?
Yes, sir.
So there is. So what do you think should happen, Pawan, when you give oxygen?
It should have improved, sir, but it's not improving.
Okay.
So it is.
What do you think at this point in
This
history? What do you think?
it is definitely cardiac cause, sir, not respiratory cause.
Okay. So you're thinking it as a cardiac cause. Excellent. So if you're thinking of a cardiac cause, what cardiac cause it could be?
Maybe shunt, sir.
Yeah, shunt. Agreed. It's a right to left shunt we are thinking of. So which right to left shunt? Do every
ASD.
right to left shunt present at birth? So this is at birth, almost within 5
Usually,
hours, the child has developed. So
ASD
whatever
ASD will present late, sir. It may be VSD.
it will be VSD.
Yes, sir.
Okay. Okay. Anyone else with any other answers? I'll just look at the chat. VSD, tricuspid stenosis, excellent. We have TOF here. Excellent. So you're thinking of an intracardiac shunt. Excellent. Avantika, excellent. Tricuspid stenosis, excellent. VSD, VSD, VSD. Okay. So always remember, guys, whenever you have a shunt goes in the direction of a gradient that should be there. Okay. So always blood flows from a high pressure to the low pressure. Okay. High pressure to low pressure. That is normal, right? So what is the LV pressure? What is the RV pressure normally? Pawan, would you like to take that since you answered this? I just want you to answer. So if we take LV and RV pressures, so which has more pressure?
LV pressures.
So for the shunt to be between the LV and RV, So if there is a shunt that is there, so what direction it will flow, Pavan?
From left to right.
Okay, so left side contains a oxygenated blood,
Yes.
and this contains a deoxygenated blood.
Yes.
So can a VSD cause something like this?
No, sir.
Cyanosis?
It should
No.
be some valve stenosis. Sir.
So some valve stenosis is good. So always remember, so ASD, VSD don't cause until unless it is like very severe from birth, and then there is severe Eisenmengers. Until then, it's unlikely. So you're thinking of a right-sided cause. So you're thinking the valve is stenosed here. Good. Then any other thing?
When pulmonary valve stenosis can cause.
Good. Then what is the artery that comes from here?
Pulmonary artery.
So pulmonary artery. Okay. So pulmonary artery. Anything else in the pulmonary artery that can be possible?
Yeah, PDS.
Again.
Yeah,
so
it might not cause.
PDS is shunt between what 2 points?
Yes. PDA will not cause.
What is the direction of movement in PDA?
From the aorta to the pulmonary artery.
Yes, aorta to the pulmonary artery. So you have oxygenated blood that is going to come.
Yes, it will not
the
cause.
child will come with failure. Heart failure the child can come with, but it won't come with cyanosis. Okay.
Yes.
So this is one more. So PDA is not there. So one more
pulmonary artery hypertension.
Pulmonary artery hypertension. Excellent. So pulmonary hypertension can be a cause. It can be because of multiple reasons. Okay. So good. Then anything else? Anything else? What if this vasculature itself is abnormal? So we are assuming that the heart is normal.
Yes.
Yes, correct. So if this is giving me rise to aorta and this is giving rise to a pulmonary vessel, then you'll still have a cyanosis. So this is transposition of great arteries. Then anything else? Okay, there's something called as truncus arteriosus, TA. Okay, then how do you remember cyanotic congenital heart disease? Anyone? There's a mnemonic, no? Cyanotic congenital heart disease. How do you remember? Starting with T. Excellent, Bhavya. Rishabh, Bhavya, excellent. So it is cyanotic congenital heart disease starts with T. So whenever you have T. So what is TOF? Tetralogy of Fallot. Okay, so tetralogy of Fallot, truncus arteriosus, tricuspid stenosis or tricuspid atresia, and a TAPVC. So these are all the causes for a right to left cardiac shunt. And there can be, we'll come to it, Epstein's anomaly that can cause an intermittent cyanosis. I'll come to it. Okay, so here we saw that even though you're giving oxygen, the lung is normal. That means the lung is normal and there is no improvement in the oxygenation. So it should be a cardiac cause. So to look at that, so we did an echo. I didn't show the echo clip. So this is the echo. So this was the picture that you got. So what are the diagnoses here, Pawan? This is my left ventricle. This is my left ventricle. This is my right ventricle. Okay. And we have this is my pulmonary artery arising from the left ventricle. And I have my aorta coming from the right ventricle.
Transposition of great vessels, sir.
Excellent. So it is transposition of great arteries. Okay.
Yes.
Any idea, any types of TGA, you know?
No.
Okay. So there's something called as a DTGA and LTGA. So LTGA is something called as a congenitally corrected transposition of great arteries. CCTGA it is called as. So that will not have cyanosis. Okay. So along with these two vessels that are being interchanged, this also, the LV and RV also are interchanged.
Yes.
Okay, the ventricles are interchanged, but the appendages of these will remain like the LV and RV. Okay, so there is something called as a congenitally corrected transposition of great arteries. Okay, so we have it as a TGA. Good. So this is a cyanotic congenital heart disease. Okay, thank you, Pawan.
Thank you, sir.
Good attempt. Okay. So what happens in TGA? I just want to very briefly tell. This is not aimed at giving the entire gist of congenital heart disease. So what happens is we have the right ventricle. So from the right ventricle, I have the aorta that comes in. Aorta gives rise to the systemic vessels. The systemic veins, systemic vessels, from there, systemic veins, they drain into the right atrium to the tricuspid valve. from the tricuspid valve again to the right ventricle. So there is no mixing of the blood at all here. So this is one circuit and this is one circuit. So that is why always a TGA will be accompanied with something. So for survival, a shunt is required for TGA to survive. So either an ASD, VSD or a PDA. So any of these three things must be there for mixing of blood from these two circulation, or else these are two parallel circulation that are running like this. So the child won't survive. So you need a shunt here. Okay. So that is the basis of your TGA. So whenever you have a TGA, so there are multiple procedures that can be done. We call it as a arterial switch or an atrial switch. Atrial switch is called as either Mustard of Senning's procedure, Jettine's arterial switch, or something called as a Rastelli's procedure. Okay. So these are all the options that are available. Just a note on that. Okay. So we stressed that we did something called as giving oxygen. So that forms the basis of something called as an hyperoxia test. What is hyperoxia test? So we take the ABG. On room air, we take the ABG, and after giving oxygen of 100% oxygen for 10 minutes. So we take those two scenarios, and if after giving oxygen the PaO2 improves, so we know that it is not a cyanotic congenital heart disease. If it is more than 200, it is unlikely to be a cyanotic congenital heart disease. If it is less than 100 or even lower, then it is definitely most likely to be a congenital cyanotic heart disease, because there is a shunt that is happening. Okay. So this is called as a hyperoxia test. Very important in pediatrics. Whenever you see a child, immediately you do this and you determine whether it is a cardiac or respiratory cause. Okay. So the next thing is, this is what I was telling you about. In the newborn period, there are 5 T's: TGA, tricuspid atresia, truncus arteriosus, TOF, if it is severe TOF, or a TAPVC. Okay. So these are the causes for a right to left shunt. Okay. So I have told you about the causes for a central and peripheral cyanosis. And in central cyanosis, cardiac causes and a respiratory cause. We can divide it like that. A cardiac cause would be a intracardiac, extracardiac shunt. Respiratory membrane defect will cause a respiratory cause. So what is differential cyanosis? Can anyone tell what is the cause for differential cyanosis? Can anyone tell what is the cause for differential cyanosis? Okay, PDA. Someone says PDA. Okay, aortic stenosis, coarctation of aorta. Okay, block of arteries. Okay. So what do we mean by differential cyanosis? First, you tell me that. So what do we mean by a differential cyanosis? So what do we mean by a differential cyanosis? Lower limb has cyanosis, upper limb doesn't. Excellent, Shashti. Yeah. So one part has cyanosis, correct. So one part of the body is affected. Yeah. So for cyanosis to occur, so let's say the upper limb is normal. Upper limb is normal. Lower limb is affected. In the lower limb, you are having cyanosis. So what will be the cause? I'm writing cyanosis with blue because it causes blue color. What should be the cause? Postductal PDA. Okay. So someone says PDA, postductal PDA. Okay. Always remember, this is what I told you that time also. So whenever you have a PDA, see, this is what is a PDA. So this is an aortic arch here. Is my this one visible, or I'll make it yellow color so that it's visible. Okay. Yeah. So this is my aortic arch here. So here I have my arteries. So subclavian, common carotid, and brachiocephalic trunk. And then this is the PDA here. So PDA comes here. So attachment. This is my pulmonary vessel, pulmonary trunk. So the aorta pressure will always be high compared to the pulmonary pressures. So this will be low. So always the shunt is going to be in this direction. Okay. So if you have a plain PDA, preductal, postductal, it doesn't matter. So let's say PDA is here. So let's say a PDA is here. So still the aorta pressure is going to be higher than the pulmonary pressure. So you will not get a cyanosis there. So what should happen is, so here you are getting upper limb is normal. So you are able to explain that here. So the upper limb here, which is supplied by all these vessels, is normal. So that means this is normal. But then here there is, so this part will supply the lower limb. So lower limb is cyanosed. So you can think of what could be the cause then. So assuming that there is a PDA, but you are getting a lower limb cyanosis in the presence of PDA, what do you think is happening? Are you getting my question? No, we'll come to coarctation of aorta. Pulmonary hypertension, yes, exactly. So there should be some cause. Excellent. So Eisenmenger's pulmonary hypertension, yes, good. So that's exactly what I was looking for. So there should be some cause for the pressure in the pulmonary vessel to become high. So if this pressure becomes high, so when the pulmonary pressure exceeds the aorta pressure, so the blood will flow in this direction and go in this direction. So because the PDA is here, so that's the same thing that is depicted here. So once the pressure in the, that's what we put plus and minus. So here the pressure in the aorta is more than the pulmonary vessels. So the flow will be in this direction. Once Eisenmengerization happens, that is, for some cause, the pulmonary pressures are exceeded. So once this is more than the aortic pressure, there will be a flow in this direction. So since the upper limbs are relatively spared, so the upper limb will be spared, whereas lower limb will be cyanosed. Okay, so this is called as differential cyanosis. Clear? Is differential cyanosis clear? So the upper limb is normal, the lower limb is cyanosed. So this is differential cyanosis. Is everyone clear of why this happens? You have a PDA that is normally conducting from the aorta to the pulmonary vessel. Because of pulmonary hypertension, the shunt reverses. So from pulmonary, it goes to the aorta, the lower limb is cyanosed, upper limb is spared. This is differential cyanosis. Is everyone clear with this? If you're clear, I'll go to the next thing. Yeah. Everyone clear? Yes, good. Okay. So this is what is called as a differential cyanosis. Okay. So you see, there is normally related great vessels, severe PAH on the right. So there is going to be a right to left shunt through the PDA. So there's going to be a severe pulmonary hypertension. So the fingers will be red, the toes will be blue. So this is exactly what is shown here. So the upper limb is fairly normal, lower limb is full dusky and cyanosed. This is, can PDA lead to pulmonary hypertension? That's what I was telling you. Plain PDA in the initial stage will not lead to pulmonary hypertension. So we'll come to that. I didn't go into Eisenmenger's. So I'll just briefly tell about what happens in Eisenmenger's. Since you have raised a very important doubt. So let's assume this is my aorta and this is my pulmonary vessels. So pulmonary trunk. So there is going to be a shunt here, correct? So this is going to be the direction of flow. So if it is coming to my pulmonary vein, so then it is going to go inside the lung. Okay, so it is going to go inside the lung. There will be some amount of increased flow across the lung. So if there is chronic more, because the aorta pressure is very high, whenever the lung is exposed to chronic pressures, so the pulmonary vessel here will respond. So whenever you are giving high force to something, the natural tendency is to resist. So that is what is going to happen at the level of pulmonary vessels. So they are going to undergo hypertrophy. The muscle will undergo some amount of hypertrophy. So that will develop pulmonary hypertension. So PDA will develop early pulmonary hypertension. Once the pulmonary hypertension increases, the pressure on the, I'll just take a simplified diagram. So this is my aorta, this is my pulmonary vessel. So there is going to be more blood flow across in this manner. And this is going to be my lungs. So there is going to be more flow across the lungs and more flow to my vessels. So more flow in the aorta, more flow to the pulmonary artery. So the pulmonary artery undergoes thickening or hypertrophy. And at some point, the pulmonary pressures become high. So once the pulmonary pressure becomes high, The same happens to the RV. So once the RV pressure becomes high, so that time the reversal of shunt happens. So that is what is Eisenmenger phenomenon. The initial left to right shunt becoming a right to left shunt, or the reversal of the left to right shunt accompanied by cyanosis is Eisenmengers. Okay. Is it clear? Just a minute, I'm not able to. Yeah, is it clear now? I just lost a connection. Just a second. Yeah. Is my screen visible? I think I lost the connection. Yeah, it's visible. No, okay, excellent, excellent. Okay. Yeah, okay. So this is the points in favor of a central cyanosis. So depending upon age group. So always remember, any diagnosis you make depends on the symptom and the time frame of the illness. So if it's an early course versus acute onset, subacute to chronic onset, the differentials will vary. So always make a diagnosis with the time frame in the background. So whenever you have a cyanotic congenital heart disease, so it is normal. So you will have early childhood, and because of chronic hypoxemia, you will get clubbing. And cyanotic spells squatting episodes, classic and tough. And you will get some cardiac murmurs. And because it is an early cyanosis, you will get so signs on the chest X-ray. Like a tough will have a boot-shaped heart, etc. And always remember, the SpO2 and PO2 will be low. This is in a cardiac cyanosis, beacon rate of cyanotic congenital heart disease. Pulmonary, usually it is a little slower onset. They will be associated with the wheeze and dyspnea. Murmurs usually are absent because it is a respiratory cause. Lung signs are present, crepitations. There can be some AV malformations in the lung itself. Abnormal lung fields, they may have some secondary PAH. And in this also, because it is central, both of this will have a low. Okay. AV malformations also similar. And this is what I was telling you, methemoglobinemia. It can be a congenital form or an acquired form. So we'll come to it later. So abnormal quality of the hemoglobin is methemoglobinemia. Okay. So the PO, the oxygen the hypoxemia will not be there. The amount of oxygen in the blood is normal. The dissolved oxygen in the blood is normal. But when you take saturation, it is abnormal. So that is methemoglobinemia. So any other volunteers for one more case? I think this is my last case. I'll end it with another 5 to 10 minutes maybe. 10 minutes I'll end it. Yeah. Anyone hearing? This is also an easy case. We'll do it together. Yeah, Rishabh. Yes, good. Let's unmute Rishabh. Rishabh, yeah. Rishabh is unmuted.
Yes, sir.
Okay, so here we have a 20-year-old male who complained of on and off chest pain and exertional dyspnea. And you also noticed bluish discoloration of the limbs as well, so which was cyanosis. So he got to know it is something discoloration happening. It had been happening for the past 4 to 5 years. And on taking some bronchodilators, he got better. And on examination, there used to be some wheeze. So they said it is probably a asthma because you have a young male presenting with chest pain and exertional dyspnea with wheeze. So the common diagnosis is asthma, correct?
Yes.
So what is the next thing you want to look at is, so here he said the family history, that the big brother also had similar complaints and he had died for this reason. So would you want to think of something, Rishabh? So big brother had such things and he passed away. Does it alarm you to something?
There might have been some complication.
Okay, there can be some complication. Good. Reversal of VSD. Good. Okay. Good. Okay. So there can be some reversal of VSD at this age. Okay. Good. Okay. So excellent. Someone has thought that way also. Excellent. Hokum. Okay. Hokum will not have much of cyanosis until unless Hokum is presently frankly in failure. Okay, so 20 years. So you can think of what are the causes you're thinking of, Rishabh. Okay, we'll go to the examination also. So important is this family history. Keep that in mind. Okay, so the elder
Yes.
brother also had. So there is some family history that is positive. So remember that in the background. So on physical examination, there is cyanosis present on the hands and lips. The saturation was 88% on room air. Okay,
Okay.
so once you have a low saturation, the immediate thing that we normally do, what do we do?
Give oxygen.
Yeah, you want to look at the oxygen saturation in the dissolved oxygen blood. So the PaO2 was 54. So it is drastically very low.
Yes.
Okay, so it is low. And patient was treated with nasal oxygen with a FiO2, which is fraction of inspired oxygen is 35, and it marginally improved. It didn't really improve much with oxygenation.
Okay.
So what
That
do you
might
think?
be a cardiac cause.
Yeah. So good. So at this point, what do you think of? At this point, we'll take it, and then we'll see what all to think of next. Okay. Yeah. So you have what all we have from the history and examination. What are the significant points we have, Rishabh?
He's an asthmatic. There's peripheral cyanosis. His elder brother
Peripheral
had.
also. Hands,
No?
lips. Yeah. Okay. So they've mentioned lips also.
Okay. Central cyanosis.
Yeah. Tongue also is involved. Okay. So I forgot to mention tongue also is involved. So you have a central cyanosis. Good. So we have a central cyanosis. Okay. We have a family history of some death in the family of the elder brother. With what do you think of next?
And there's no improvement with the oxygen.
So hyperoxia test is positive.
Is positive.
Yeah. So it's not improving. So what do you think of now?
Cor pulmonale.
Cor pulmonale. Okay. So for cor pulmonale, what all should be there?
There should be a right heart failure secondary to the lung pathology.
Okay. So you're thinking of a chronic lung pathology that is causing cor pulmonale. So you're thinking
Yes.
asthma is caused cor pulmonale.
Maybe.
Okay. Good thinking. Okay. Anything else you want to think of? You were telling at that point. So with oxygen, it's not improving. So what else you want to think of?
Shunt disease.
Shunt, excellent. Okay, so either an intracardiac or extracardiac shunt. Good. Then Eisenmenger, excellent. Someone says ILD. Okay, ILD with so much cyanosis at 20 years of age, ILD unlikely.
Congenital heart disease.
Congenital heart disease, good. So congenital heart disease. So what kind of congenital heart disease you want to think of here?
Because there's cyanosis, so cyanotic.
Which cyanotic heart disease presents at 20 years of age, Rishabh? So can there be some cyanotic heart
EST.
disease presenting at 20 years of age?
Cyanotic, okay. TOFs.
Okay, maybe, but you will have some signs before only. Okay. You said VSD. Okay, so VSD is acyanotic.
Yes.
So acyanotic, that is getting reversed. So you can think of
Eisenmenger.
if the VSD is a little large VSD, it could have caused Eisenmenger's. Excellent. So you should think of Eisenmengerization. Okay. Hypersensitivity pneumonitis. Okay. Maybe, yeah, that can also be possible. Okay. Good, Rishabh. So what we are thinking essentially is a cardiac cause or a respiratory cause. So these are the two things we are thinking of.
Yes.
If cardiac, you are thinking of a reversal of shunt, which is Eisenmengerization. So at this point, at this stage of Eisenmengerization, PDA and VSD are the likely possibilities. If there is a PDA and VSD, patient would have noticed some features like palpitations,
yes,
easy fatigability, all these symptoms patient will have. Okay. So with that in mind, we look at the systemic examination. But systemic examination, there was nothing.
Okay.
So you're expecting something. So you said cor pulmonale. So you expect some RV pressures to be high. So you expect some pulmonary hypertension. So lower P2,
Yes, sir.
some ESM in the pulmonary area. So nothing of that sort is there.
So we can rule out that.
It's not a cardiac, it's not a respiratory.
Then vascular.
So you should think of vascular cause. Good. So what we did was, this was the X-ray you want to look at. So this is the X-ray. The X-ray is normal.
Yes.
So what do you want to do next? The first case I told you something.
ABG.
Yeah, OABG is done here. The PaO2 was 54. The ABG. So there is frank hypoxemia with a near normal saturation. Okay.
Okay. So
you want to think of shunt. So it can be extracardiac, intracardiac. So for extracardiac shunt, you should do a bubble stent
yes,
or some
bubbles.
other echo. Okay.
Yes.
So like you said, you want to look at the vasculature. So we had done a vasculature for this. I don't have the photo of it. So we did a angiogram, pulmonary angiogram, and it was normal. Okay.
Okay.
And an echo was done. Echo also was normal. So we have ruled out a shunt. We have ruled out an intracardiac or extracardiac shunt.
Yes.
So what are we left with next? So the lung looks normal. CT chest also was done, which was normal. So what are we left with next?
The hemoglobins.
So yes, so you want to look at some abnormal hemoglobins.
Yes.
We did a abnormal hemoglobin. So the serum methemoglobin level was elevated. So methemoglobin
Okay.
was 40 times the normal. So what do you think of the diagnosis here?
Methemoglobinemia.
Okay, what could be the cause for methemoglobinemia? So since you are thinking of a methemoglobin elevation, so you want
Yes.
to ask something in the history that can be significant.
Use of
Yes,
drugs.
you want to cause? Yeah, good. Drugs. Excellent. So what drugs you want to think of?
I don't remember.
Drugs causing methemoglobinemia. Good. You are thinking of drugs. Excellent. So anything else that can be there? Any occupational exposure that can be there?
Lead poisoning.
Yeah, lead poisoning will not cause respiratory difficulty. But like if he's someone had told, no, hypersensitive pneumonitis, that can be one.
Yes.
If it is
Okay.
chronic. Okay. And any heavy metal injury or these, whatever you said as drugs, no, even toxin exposure can cause elevated methemoglobin levels.
Yes.
Okay. So those are the causes you are thinking of. Excellent.
Yes.
So the common causes what we think of is these drugs. So someone said sulfonamide. So sulfur drugs, dapsone. Excellent. So these two are notorious to cause methemoglobinemia. So here this
Yes.
fellow said there is no history of any drug intake. Other drugs
Yes.
that can cause is PAS. You've heard of PAS, no? Para-amino-salicylate acid.
Yes, sir.
And some aniline dyes that are used in our food and all that can all cause this.
Okay.
Okay, so primaquine also. Very important is primaquine. Primaquine can also cause this.
Okay.
Okay, so these are the things. So what do you think here? So there is no drugs here. So what would be the cause? It could be congenital or it will be acquired here.
It'll be congenital because his brother also had it, maybe.
Excellent. So that is why I said you remember the family history also. So we had a family history here and patient had a similar symptoms and he passed away. So there was congenital history.
Congenital meth. Yes.
Probably it's a congenital methemoglobinemia. Excellent.
Yes.
Okay, good. Thank you. Thank you, Rishabh.
Thank you, sir.
Yeah. So here we treated him with methylene blue. Methylene blue will bind to the methemoglobin and will reduce the levels. So methemoglobin levels reduced to 8 to 9%. And after giving methylene blue, the patient improved. So the saturation improved to 94 to 96%, and he was discharged. Okay. Yeah. Yeah. Someone is asking. Yeah. Mention that there will be no cyanosis and methemoglobinemia. Yeah. If it is severe, you can have. That's what I was telling you. So usually whenever there is methemoglobinemia, there is abnormal reduced hemoglobin. So there are abnormal hemoglobins. If the abnormal hemoglobin crosses a threshold, then you will have cyanosis. That's why initial slide I had mentioned here, defining cyanosis. How do we think of a cyanosis? Is a disorder of deoxygenated hemoglobin or an abnormal hemoglobin. So these two things can cause cyanosis. Okay. Yeah. Fine? Clear? Yeah. Okay. So is everyone clear of how we'll approach cyanosis? I think I end by this one. Yeah. That's it for today. Any questions? I'll take it from here. Maybe 10 minutes or 5 minutes for questions, and we'll close the session. Any doubts? Anything you can ask? Okay. So I'll just recap the whole thing. So what do we mean by cyanosis? I'll just run through the slides quickly so that we recap it. Okay. I forgot to tell you one small thing. There is something called as an intermittent cyanosis. Okay. Intermittent cyanosis. Can anyone tell where do you get intermittent cyanosis? Yeah. Someone has asked. Excellent. Yeah, where do you get intermittent cyanosis, Jeevan? Yeah. Epstein's anomaly. Excellent, Srishti. Yeah. Good, Srishti. Good. So what happens in Epstein's is, so this is my heart. I'll be a little slow in this diagram. I want to show something important here. Okay. So this is my right side. This is my left side. Okay. So what happens is, this is my tricuspid valve that is going to be here. Okay. But what happens in Epstein's is, this tricuspid valve is placed lower down. So it is going to be here. So what happens is, this is my portion of the ventricle. Okay. This is the ventricle. So normally this should be the ventricle cutoff. But what happens is, because the tricuspid valve is placed very low, what happens? This part of the ventricle becomes atrialized. That means now the effective atrium is going to be this whole part. One will be the normal atrium proper and a atrialized right ventricle. Okay, you are getting this point, atrialized right ventricle. Okay. So this is what is Epstein's. So the effective ventricular volume is going to be very less. Effective ventricular volume is going to be very less. Okay. So usually Epstein's is associated with other abnormalities as well. You will have some associated ASD or VSD. So if this is going to be my heart, I'll just change it. So this is my Epstein's anomaly. This is going to be Epstein's. So here, this part, these dotted lines will represent my atrialized right ventricle. I'll just write it as RAV, atrialized right ventricle. Right ventricle which is atrialized. So that ventricle is followed by the atrium. So what happens here is, there is less blood in the ventricle. So there is going to be a high amount of blood that is going to be present in the atrium. Okay. So whenever there is some ASD, usually there will be some ASD. So whenever these pressures increase, so whenever this RA pressure increases to a very great extent, there will be a shunt through the right atrium to the left atrium, and that will cause intermittent cyanosis. Okay, so this is how intermittent cyanosis works in Epstein's. There will be some amount of blood filling in the ventricle also, and there will be pumping of blood also. So whenever this blood in the atrium improves, so whenever the blood in the right atrium is more than the blood in the left atrium, so there will be a shunt, so you will get an intermittent cyanosis. That is what is Epstein's. And can anyone tell the electrophysiologic abnormalities you can see in Epstein's? There's one classic association with Epstein's. Usually. Anyone knows? I've not covered it in my ECG session, but in case you know. Perfect. Himalayan P waves. Perfect. Okay, yeah. Along with Himalayan P waves, anything else? Yeah, perfect. WPW. Yeah. Good. So I don't know your names. Yeah. So these are the two things you should remember. So what do you mean by Himalayan P wave is? So the P wave will be bigger than the QRS complex. So the P wave is larger than the QRS complex. That is called as a Himalayan P wave. So it appears like the Himalayas. So this will be the QRS complex and the T wave. So this is the Himalayan P waves that is seen in Epstein's anomaly. Why you get it is because As you know, the entire RA is huge. So that is why you get a Himalayan P wave. Along with that, like your friend said, you will have a coexisting WPW. Okay. Yeah. So we know. Okay. So that is about. I think that finishes cyanosis for us. Cerebral discoloration and not cyanosis. Okay. Yeah. I'll come to it. Yeah. I'll just recap this and I'll come to the questions. Okay. So what do we mean by cyanosis? Cyanosis is increase in the reduced hemoglobin levels. So it occurs only when the hemoglobin, deoxygenated hemoglobin, is more than 3 to 5 gram per deciliter. So the causes can be a central or peripheral. Central is because of a shunt or a respiratory cause. A shunt can be an intracardiac or an extracardiac cause. A peripheral cyanosis is because of something happening at the level of extremities, wherein because of low flow, there is increased utilization. So therefore, there will be a cyanosis. Upon warming, it may improve. So we saw about the causes for peripheral, you can remember as cold, and the central cyanosis as palms. Okay. So we saw some cases. So the most common, so we should know the hyperoxia test. So in the newborn period, you can remember congenital heart diseases, cyanotic congenital heart disease as 5Ts, TGA, tricuspid atresia, tricuspid stenosis, TAPBC, truncus arteriosus, and TOF. There can be something called as a hypoplastic RV and pulmonary atresia with hypoplastic RV. It's just nice to know if you can remember this. So the causes we know. So then the types, other types will be a differential cyanosis, a reverse differential cyanosis, and intermittent cyanosis. A differential cyanosis, whenever there's Eisenmengerization occurring through an intact PDA, you will get this. Okay. So whenever you have, there's something called as a reverse differential cyanosis, which I forgot to tell. A reverse differential cyanosis, like everyone was telling. So you were telling about coarctation of aorta. So whenever there is coarctation of aorta with pulmonary hypertension and a DTGA, you will get a reverse differential cyanosis. So the upper limb here will be blue and the lower limb will be pink. So that is reverse differential cyanosis. So then this table we had summarized. So if you are not getting, so the first step would be if you are getting a central cyanosis, you look at the shunts. To intracardiac shunt, you can look at the echo. For an extracardiac shunt, you can look at the bubble study. So when we look at bubble study, within 3 cycles, if the bubble comes inside the left side, it is an intracardiac shunt. If it is coming after about 4 cycles, it is an extracardiac or probably a intrapulmonary shunt. Okay. So if none of these are there, so the angiogram is clean, the heart is normal, the lungs are normal, so the vasculature is normal, you look at abnormal hemoglobin, which is rare. So we saw a case of methemoglobinemia. Okay. So that's it for cyanosis. So give oxygen if it doesn't improve. Yeah, nail fold test you want. Okay, yeah. So nail fold test is something we use to differentiate between a primary and a secondary Raynaud's. So it's called as nail fold capillaroscopy. You can just look it up. There will be abnormal vessels there will be destruction of the normal vessels in a secondary Raynaud's, whereas it will be preserved with some looping and bending that is normally seen in a primary Raynaud's. So the nail is preserved in a primary Raynaud's and it is destroyed in the secondary Raynaud's, which is secondary to most commonly an autoimmune cause. You can have a scleroderma, you can have an SLE that can cause this. So that is a nail fold test. You can just press a slide and you can see through it. Yeah. Okay. Yeah. Fine. In the first case, there was type 2 respiratory failure as well. I'm not sure. I'll have to look at it. Probably it was there. I don't know. Just a minute. No, there is no type 2 respiratory failure. For type 2 respiratory failure, there should be hypoxemia with hypercapnia. The normal PaCO2 is 40. Okay. So there is no type 2 respiratory failure there. Hypoxemia with hypercapnia is type 2 respiratory failure. Okay. Yeah. Why you don't get in carbon monoxide poisoning, you don't get cyanosis is there will be some amount of polycythemia also. There will be flushing of the vessels. Carbon monoxide is a very good vasodilator. So because there is going to be effective vasodilatation, and as well as some amount of polycythemia because of some chronic insult like this, you may not see cyanosis. But yeah, it is classically described as a cherry red coloring. So probably it's secondary to vasodilation. Maybe we'll get back with this answer, but as far as I understand, it's because of the severe vasodilation that can occur because of carbon monoxide poisoning with a reduced affinity. Yeah. Okay. Yeah. So if everyone is clear, I think we'll end for today. Any doubts, you can put it in the White Army groups. We'll be taking it. Okay. So just